So, I want you to imagine a space roughly the size of a coffee thermos. Now, take your airway, your esophagus, vital blood vessels, major cranial nerves, and like a massive network of immune checkpoints, and cram all of that tightly inside it.
Right, it's a tight fit.
Yeah, exactly. Welcome to the human neck. It's a place where a surgeon's margin for error is, often just a single millimeter.
It really is an absolute marvel of biological packaging.
Yeah.
But it is incredibly unforgiving. Like a tiny deviation to the left or the right during a procedure can
completely change everything.
Exactly. It can mean the difference between preserving a patient's voice, their ability to lift their arm, or honestly, their very life.
Wow. Usually when we talk about a medical diagnosis, there's this expectation of like clean binary precision.
Right.
Break an arm, the X-ray shows a jagged white line, and the doctor just points to it.
Yeah, very straightforward.
But stepping into the world of head and neck oncology means stepping completely away from that comfort zone. We're looking at a diagnostic and surgical landscape that is incredibly high stakes, deeply complex, and sometimes pretty murky.
Very murky.
So welcome to this custom-tailored deep dive. We have a fascinating stack of medical sources today, and our mission is to decode this hidden architecture. We are going to understand exactly how surgeons navigate this treacherous terrain to eradicate solid cancers, and then we're going to explore the systemic whole-body battleground of lymphoma.
And if you've ever looked at raw anatomical charts of the neck, it can honestly feel like trying to decipher the blueprints of a nuclear submarine.
Without an engineering degree.
Right, without an engineering degree. But underneath all that complexity, the underlying logic of the human body is just brilliant.
It really is, and we are going to extract those aha moments for you, turning a dense anatomical map into a gripping story of human engineering and medical mastery. Okay, let's unpack this.
Sounds good.
Before we can even talk about how a surgeon operates on the neck, we have to understand the map they use, right? The defining landmark of the neck is a muscle called the sternocleidomastoid, or the SEM for short.
Yeah, that's the big one.
If you turn your head sharply to the side, it's that prominent, thick band of muscle that pops out right behind your ear, anchoring all the way down to your collarbone.
And that single muscle effectively draws the primary borderlines. It divides each side of the neck into two main zones. You have the anterior triangle, which sits in front of the SEM, and the posterior triangle, which sits right behind it.
But it isn't just like an open bucket of parts divided in half, right? The entire neck is categorized by these intricate layers of tissue called fascia.
Yes, the fascial layers are crucial.
Like just under the skin, you have the superficial fascia. This holds the platysma, which is that super thin, sheet-like muscle that, flares out on your neck when you grimace.
Right.
But beneath that, the deep fascia creates this truly wild system of internal compartmentalization.
It's not just a single wrapper either. The deep fascia actually has distinct sublayers that serve highly specific mechanical and protective purposes.
Oh, wow.
Yeah, so you have the investing layer, which wraps the entire circumference of the neck just under the superficial layer. Then, deeper inside, the prevertebral fascia forms a really tough, tight sleeve around the spinal column and the muscles supporting it.
Okay, so that's the back. What about the front?
In the front, the petrogal layer wraps the airway and the thyroid gland.
And then there's the carotid sheath, right, acting as a sort of high-security conduit just for the common carotid artery, the internal jugular vein, and the vagus nerve.
Exactly.
Visualizing this, it is basically like biological shrink wrap, or maybe more accurately, a system of Russian nesting dolls made of tough connective tissue.
That's a great way to put it.
You open one layer, and the respiratory system is perfectly sealed off, open another, and the vascular system is completely isolated. It keeps all these distinct functions.
Air, blood, nerve signals.
Yeah, keeps them organized and separated from each other in an incredibly tight space.
And that structural isolation is exactly what allows surgeons to operate without collapsing the whole system. By knowing exactly which fascial layer wraps which organ, a surgeon can glide their instruments along those natural bloodless planes of connective tissue.
Wow.
They literally use the shrink wrap to guide their scalpels, safely bypassing a major pulsating artery to reach a tumor on the airway.
Looking at how these fascial layers are positioned, though, it seems like they create empty zones or fascial spaces right between the layers.
They do.
And the one that really stands out in the sources is the retropharyngeal space. It sits right between the fascia covering the back of the throat and the prevertebral fascia covering the spine. Since it runs down the back of the throat, it doesn't look completely sealed off at the bottom. Does that mean it connects directly into the chest cavity?
If we connect this to the bigger picture, it connects directly into the posterior mediastinum, which is deep inside your chest cavity, right behind your heart.
Wait, really? Just a straight shot down?
A straight shot. Because it is essentially a vertical tube of loose connective tissue, it acts as an unobstructed highway. If a severe infection builds up in the throat, or if a highly aggressive cancer breaches the muscular wall of the pharynx into that specific space, gravity and internal pressure can push that disease straight down.
Oh man.
Yeah, a localized neck issue can escalate into a life-threatening thoracic emergency incredibly quickly, simply because that natural fascial barrier isn't there at the bottom.
So the map itself provides the exact pathway for the danger to spread. That completely reframes how you have to look at head and neck cancer.
It really does.
When a solid tumor strikes, say in the oral cavity or the vocal cords, the surgeon isn't just looking at the tumor itself, they are mapping the highways leading away from it, which brings us directly to a procedure known as a neck dissection.
Precisely. And the physical checkpoints along those highways are the lymph nodes. In the neck, there are hundreds of lymph nodes, but surgeons meticulously categorize them into specific levels, numbered I through 6.
Roman numerals, right?
Right. Level I sits up high, right under the jaw, capturing drainage from the mouth and lips, while levels further down, like level 6 near the collarbone and thyroid, act as lower tier filters.
To access those checkpoints, surgeons have to open up the neck, and the physical geometry required to do that safely gives us these surprisingly vivid surgical approaches.
The names are very descriptive.
Yeah, you have incisions called the boomerang, the hockey stick, the apron, and the McPhee.
Yep. Depending on the primary tumor's location and the lymph node levels at risk, the surgeon selects a specific geometric cut to maximize visibility while minimizing the disruption of blood flow to the skin flaps.
But getting the neck open is just the beginning, isn't it? The core philosophy of a neck dissection, like how much tissue to actually take out, has undergone a massive, decades-long evolution.
Oh, absolutely. For a long time, the absolute standard approach was the radical neck dissection, or RND.
And radical really is the right word here. And RND removes lymph node levels 1 through 5. But to get them all, it also removes the entire SCM muscle we talked about earlier, the internal jugular vein, and the spinal accessory nerve. It is a scorched earth approach.
It is profoundly altering for the patient. Removing the SCM changes the entire physical contour and the rotational strength of the neck.
I can imagine.
And clamping and removing one of the internal jugular veins forces the body to suddenly reroute half of its cranial blood drainage through the opposite side of the neck.
But the sacrifice of the spinal accessory nerve seems to carry the heaviest functional cost.
Yeah.
Because that nerve powers the trapezius muscle, right? That huge kite-shaped muscle covering your upper back and neck.
Exactly. Without the spinal accessory nerve firing electrical signals to the trapezius, the muscle quickly atrophies. The patient suffers from what we clinically call shoulder drop. They lose the mechanical ability to shrug or elevate their arm above horizontal. The arm essentially hangs dead at the shoulder joint, which stretches the surrounding ligaments and causes chronic severe pain. It is a tremendous price to pay for cancer clearance.
The justification for all that collateral damage comes down to a critical surgical concept called en bloc removal, meaning they remove the lymph nodes, the muscle, the vein, and the nerve in one continuous connected piece. But wait, if the cancer is primarily localized inside a few specific lymph nodes, why take out all the surrounding tissue in one giant massive chunk? Why not just meticulously pluck out the bad nodes, like picking bad grapes off a vine?
Well, plucking the bad grapes intuitively makes sense, but it ignores how cancer travels. As tumor cells move through the microscopic lymphatic channels between the nodes, they can easily get stranded in the intervening connective tissues.
Okay, I see.
If a surgeon tries a discontinuous removal, plucking a node here, dissecting a separate channel there, they slice right through those microscopic transit routes.
Which whisks spilling microscopic cancer cells right into those pristine fascial spaces we just talked about.
Exactly. Once those cells spill into the open surgical field, they will seed and return, often in a much more aggressive form. En bloc ensures you pull out the diseased nodes and their entire surrounding microscopic environment as one contained sealed package.
So it's like,
You don't try to defuse the bomb in the living room, you carry the whole blast-proof box outside.
okay, that makes total sense. But taking the whole box doesn't always have to mean taking the house with it. This is where the surgical shift toward the modified radical neck dissection, the MRND, and the selective neck dissection, the SND, comes in.
Yes, exactly.
If the tumor isn't physically invading the wall of the internal jugular vein or wrapping around the spinal accessory nerve, modern surgeons can perform an en bloc removal of the lymphatic tissue while carefully stripping it away from those vital structures.
It is the absolute pinnacle of anatomical mastery. They carefully unshrink wrap the spinal accessory nerve, clear the infected lymphatic tissue completely around it, and leave the nerve intact and functional.
That's incredible.
It is. The survival and cure rates remain statistically identical to the old radical approach, but the patient completely avoids shoulder drop. They keep their venous drainage. The quality of life is exponentially higher.
That transition from radical to selective dissection shows a deep understanding of treating the lymph nodes as the victims of a spreading solid tumor. The cancer started elsewhere, like in the mouth or throat, and the nodes just caught the debris.
Right.
But the paradigm completely flips when the lymphatic system itself is the cancer, which brings us to lymphoma.
Specifically, non-Hodgkin lymphoma, or NHL, which is the most common type found in the head and neck region. When the immune checkpoints themselves go rogue, the surgical rules we just discussed no longer apply.
The first major difference is how you even identify the enemy. If someone has a swollen node, a common first step is an FNAC, fine needle aspiration cytology.
Right, the needle biopsy.
You insert a thin needle, pull out some cells, and check them under a microscope. But an FNAC has a major blind spot with lymphoma. It can grab individual cells, but it completely destroys the structural architecture of the tissue in the process.
This raises an important question regarding diagnosis. Think of a lymph node, like a sprawling office building. An FNAC is like throwing a grappling hook through a window, ripping out a desk and a chair, and pulling it back outside.
That's a brutal image, but yeah.
You can look at the desk and confirm you found malignant cells. But you have no idea if those malignant cells were localized in the lobby, or if they had infiltrated the CEO's office, or if they were breaking down the structural foundation in the basement.
And because lymphoma has dozens of distinct subtypes, knowing the exact floor plan is required to choose the right treatment. Are the cells destroying the outer capsule of the node? Are they forming little distinct nodules inside?
Exactly. You can't see any of that from a puddle of loose cells on a slide.
Which is why a surgical open biopsy is the absolute gold standard here. You have to remove the entire intact lymph node, slice it in half, and examine the uncorrupted geography under the microscope to precisely categorize the lymphoma.
Right. The physical structure matters just as much as the cells.
Once you have that precise diagnosis, staging the disease is completely different from staging a localized throat cancer. We use the Lugano modification of the Ann Arbor system. And here's where it gets really interesting. They literally use a dividing line in the human body for staging. The diaphragm, the structural muscle you use to breathe.
It functions as a biological equator.
Stage 1 and stage 2 mean the affected lymph nodes are on the same side of the diaphragm, so you might have disease in the neck or the neck and the armpit.
Right.
But stage 3 means the cancer has crossed the equator. You have involved nodes on both sides of the diaphragm, above in the neck and below in the abdomen. And stage 4 means it's spread outside the lymphatic system entirely into extra lymphatic organs like the liver or bone marrow.
And using that geographic map highlights the systemic nature of the disease. It explains why surgery is almost entirely benched as a treatment option. You cannot perform an unblocked resection of a patient's entire circulatory and immune system.
Although there is one highly specific outlier where surgery actually is curative for lymphoma, is for something called MALT1E in the thyroid gland. MALT stands for mucosa-associated lymphoid tissue.
Yes, that's the one exception.
Because this specific type of lymphoma arises in the localized lymphoid tissue of the thyroid, rather than spreading through the systemic node network. Physically removing the thyroid gland can sometimes eradicate it completely, but aside from that rare exception, the real weapons are systemic therapies.
You have to fight a whole body war with whole body therapies. The standard heavy artillery is CHOP chemotherapy. It's a powerful combination of cyclophosphamide, doxorubicin, vincristine, and prednisolone.
And rather than just hoping the poison works, each of those drugs is specifically chosen because it sabotages the cancer cell's life cycle in a different way. Like, cyclophosphamide might physically bind and shatter the cell's DNA so it cannot replicate,
right,
while vincristine physically destroys the internal scaffolding of the cell as it tries to divide. It's designed to flood the bloodstream and overwhelm rapidly dividing cells from multiple mechanical angles.
But traditional chemotherapy is essentially a carpet bomb. It hits healthy, rapidly dividing cells alongside the malignant ones. That's why the addition of immunotherapy, specifically rituximab, which turns CHOP into GCHOP, was such a massive breakthrough in oncology.
If CHOP is the carpet bomb, rituximab is the targeted sniper. It's an engineered antibody that specifically hunts down a protein marker called CD20, which is heavily present on the surface of these rogue B cells. Once it binds to that marker, it essentially paints a neon target on the cancer cell, signaling the patient's own remaining healthy immune system to come in and destroy it. We go from navigating fascial highways with a scalpel to utilizing the bloodstream to deliver biological homing beacons.
It is a profound shift in tactics. The surgeon handles the tactical extraction for solid tumors, but the medical oncologist orchestrates a microscopic, systemic siege for lymphoma.
Stepping back and looking at this massive amount of information we've unpacked, it's incredible how our approach to the human body completely changes depending on the threat. We started at the foundation, tracing the microscopic, shrink-wrapped anatomy of the neck, the deep fascia, the surgical triangles, and that hidden unobstructed highway sliding straight down into the chest.
We explored the physical geometry required to navigate that space safely, watching the evolution from the brutal, scorched earth approach of the radical neck dissection to the elegant precision of the selective dissection, removing the threat while meticulously preserving the delicate nerves and vessels that give a patient their quality of life.
And finally, we saw how the rules rewrite themselves when the lymphatic system itself turns against the body in lymphoma. Using the diaphragm as an equator to map out a systemic war, swapping scalpels for complex, targeted chemical chemical and biological strikes.
That's a huge shift.
But as we wrap up today's deep dive, there's one final highly counterintuitive detail regarding head and neck surgery that I want to leave you with. It involves what's called an elective or prophylactic neck dissection.
Yes. This is the clinical dilemma of the N0 neck, node 0.
Right.
A patient has a primary tumor, let's say, on their tongue, but their neck lymph nodes feel perfectly normal. There is no palpable disease.
Right.
Do you aggressively cut out the healthy seeming nodes just in case microscopic cancer is hiding there?
For decades, the reflex was absolutely cut them out to be safe. But modern insights suggest something entirely different. Removing these unaffected nodes can sometimes remove a critical barrier to cancer spread. The lymph nodes aren't just passive filters.
Right, they're active.
They are actively generating an immunological response against the primary tumor. If you proactively strip out that healthy lymphatic tissue, you actually create a poorer immunological environment for the patient. And often, it is an unnecessary surgical trauma because targeted radiation can be equally effective at cleaning up microscopic disease without permanently dismantling the patient's anatomy.
Exactly.
So I want you to mull this over. In our aggressive, deeply ingrained quest to cut out disease before it can spread, what if we are sometimes unknowingly dismantling our body's own natural roadblocks? It turns out, in the deeply complex, beautifully organized architecture of the human body, knowing exactly when not to cut is just as masterful as knowing exactly where to.